Hi everyone, my name is Lynn James, and my study is on the effects of aversive treatment on aberrant behavior. Okay, so before we begin, I wanted to give a little background information about this study. So, for anyone that is not familiar with the term aversive, and aversive treatment is an intervention used as a punishing stimulus as a procedure for behavior modification and is usually applied when dealing with self-injurious behaviors. One of the most common behaviors children with autism face is aberrant behavior, which consists of many different types, such as head hitting, kicking, intensive scratching, and biting. And each one of these behaviors require different treatments that may be more aversive than others. So, for more severe cases, such as self-injurious behaviors, they are the most dangerous and they can also potentially be life-threatening to oneself or to others. Some aversive behaviors that are still commonly used in ABA are electric shocks, physical restraints, and loud verbal responses to inappropriate behaviors. For example, a treatment done on head hitting mentioned by Linshed was about individuals with self-injurious behaviors who wore a sensory module on their head, and this device sent an electrical stimulus throughout the body and into the heart, preventing the individual from severe head hitting. And all of these approaches are done only after the fact that they've tried least aversive approaches before going to the next extreme to make sure that participants got the chance to receive least aversive approaches before going to the next extreme. While there are many advantages to aversive treatments, there are also a number of concerns for using them. So, when looking at problematic behaviors, in some cases, positive reinforcement would be best, but it's not always as motivating as an aversive treatment. In any case, before implementing an aversive treatment, the procedure needs to be examined and pre approved before being performed on anyone. The American Association on Mental Deficiency has been put in place to avoid any unethical situations. They are very strict on examining the procedure before an individual is implemented on, and they analyze the long and short term effects that can arise after the study is completed. They do this by reviewing the study a number of times before exposing anyone to it. By doing this, it reduces any internal and external threats that may arise. The federal government has precise rules as well when using aversive treatments, and they have three rules in place that are one, that the procedure is reviewed and approved by the Human Rights Committee. Two, that an informed consent needs to be signed by the participant themselves or a guardian if the individual is not able to consent to a study or if they're not of age. And this simply states that they understand the advantages and disadvantages of the treatment. And lastly, a written document on file where the intervention is going to be done. So, for my study, it consisted of 3 preschool children diagnosed with autism. All 3 individuals attended ABA therapy 5 days a week through a clinic called Applied Behavioral Interventions in Chicago. All three participants were volunteered through their parents, who were emailed about the study through ABI's management coordinator. Before implementing the procedure, each parent had to sign an informed consent stating they gave permission to perform the treatment and that they understood the possible risks and results of the treatment. All sessions were conducted in a 170 square foot 13 by 13 classroom. This included a small work table and 3 chairs. The materials used to evoke the aberrant behavior were 3 laminated expressive label cards, which were kangaroo, plate, and bike. These 3 expressive label cards were not in the individual's repertoire. There was also 3 other maintenance cards also put in place as distractor trials, which were cat, fork, and swing, and these were in all 3 individuals' repertoire. These 6 cards were mixed up in a stack in front of the instructor. The instructor would present each card to the participant and ask the question, "What is it?" If the participant answered correctly without biting themselves, the instructor would move on to the next card. When the individual answered incorrectly, the instructor would ask the question again, which resulted in the child saying the same response, then biting itself from frustration. This is when the instructor would spray the participant in the eyes for biting. The device used was an 8-ounce clear spray bottle that showed the 8 ounces of water inside the bottle for the participant to see. And the spray bottle had 2 settings. The first one sprayed more water, which is the one that was used in the experiment. The participant was on the opposite side of the instructor who was conducting the experiment, and the bottle was on the right side of the instructor for easier access when the aberrant behavior occurred. The treatment was done during 1 p.m. to 6 p.m. each day for 20 days straight. And for data collection, each sheet was labeled with the first initial of the participant's name, along with the session number and the table to keep track of the frequency count. I chose a multiple baseline design because it was easier to see how significant of a change in behavior occurred once the treatment was applied. The result for all 3 participants had a positive effect on the aversive treatment. As you can see in Figure 1, named Grayson, he showed to have a stable baseline for all 4 sessions with an average of 28 bite marks per session, and on the 5th session, the treatment was implemented. Right away, there was a decrease in biting from 28 bite marks to 12 just within the first day. And in Figure 2, Nick, who had a baseline phase for about 9 sessions, ranged from 27 bite marks per session, and at session 10, the intervention was implemented, and his biting showed a downward trend as well. It dropped from 27 to 10 bite marks within the first intervention phase. And in figure 3, conducted on Xavier, his baseline phase was for 14 sessions with an average of about 21 bite marks. And at session 15, the intervention was applied. The intervention phase had a slower effect on Xavier out of all three, and once intervention was applied, his biting decreased from 21 to 15 on the first day. But out of all three participants, Nick seemed to have the quickest effect once intervention was applied, and Xavier had the slowest. But surprisingly, for all three participants, it only took about 5 sessions after intervention was implemented to get the behavior from mid-20s to 0. And by looking at the graph, you can see by the dotted arrows a clear indication of when each participant received the intervention. Some limitations that can improve for future study would be generalization to other settings. For instance, to conduct the experiment in a more naturalistic setting, such as the participant's house or the school they attend, with other individuals around them, such as classmates, maybe family members, rather than doing it in such a contrived setting like this study. Another one would be to see if the treatment would be effective all day instead of just those 5 hours from 1 p.m. to 6 p.m. And lastly, to examine different age groups to see if the treatment would work with individuals in their 20s and 30s, not just children. This study concluded that the use of aversive treatment reduces self-injurious behavior, especially on biting. Aversive treatments are the most appropriate for children diagnosed with autism, and although they may be more unpleasant to use, they are the most effective. Mentioned earlier, aversive treatments should be used mainly for self-injurious behaviors, especially when other treatments are ineffective. The water spray worked just as effective as another study written by Bailey on water mist for children who were mentally disabled. And for my study and Bailey's study, it both showed a decrease in the aberrant behavior. And for this study, there were some potential threats to validity because for each child, the behavior analysis that worked on the study with them also did ABA with them. And this could also have played a factor on whether or not the behavior changed with the intervention or the BCBA themselves plus the intervention. Some external abilities that could have been enhanced in this study are by applying the intervention during a more naturalistic setting, such as their home or the park or even school. Another reason would be for different individuals to interact with the participant and to see if the treatment was just as effective with them as it was with the BCBA. along with the events behind the aberrant behavior, and whether or not it would have been as effective when participating in different activities. Um, 3 improvements for future studies would be to add a bad tasting food dye to the water and spray it in the mouth instead of the face to see if it would be more or less effective that way. Another development would be to run it in different settings, such as a more naturalistic setting rather than a contrived, maybe in the participant's classroom. This way, it'll be more distractors and see if it's just as effective or not. And lastly, to follow up a year later to see if the participant's biting remained at a 0 or if an extinction burst occurred where the treatment was just ineffective and it just came back. And that is it. Thank you, everyone.